Whoops. Didn't know you were hitting that. Okay. Well, I really do appreciate the opportunity to come and talk to y'all. I'm Joe Cunningham, and it says I'm from Blue Cross Blue Shield of Oklahoma. I really work for a company that is probably the largest company that you've never heard of, and that's Healthcare Service Corporation, and we operate 5 Blue Cross plans. We have Oklahoma, Texas, Illinois, New Mexico, and Montana. And within those 5 plans, we are the largest not-for-profit or non-investor-owned payer in the United States. We're also the 4th largest payer of any kind. So when we talk, I do live in Oklahoma, and a lot of my primary responsibilities in Oklahoma, but I have the opportunity to engage in the other states, large states, Illinois, Texas, small states, New Mexico and Montana, and we like to say we're kind of the right size or the Goldilocks state, because it seems that we're able to do things that smaller states can't, and also larger states are too encumbered by doing things the way they always did. I was asked by Terry Klein, many of you all know him. He's a good friend of mine, past president of ASTHO, and then I had discussions with Paul to come and talk to this organization about Million Hearts, but really not about our Million Hearts program specifically. I will talk just a little bit about it, but really I was asked to talk about why we wanted, as the largest payer in our state, to participate in these type of initiatives. And I think that's really important. So that's really what I want to spend the primary part of what I'm talking on. And also I'll try to keep it rather short, because one of the allures for me to come talk is that I enjoy panel discussions and I like unrehearsed questions, and that's things that really kind of excite me. So just a basic of our Million Hearts, we call it Heartland Oklahoma. It's really fundamentally a care coordination model, and it's based on blood pressure control and a significant emphasis on medication adherence. We have patients that are referred into the program from any primary care provider. Anybody that's seeing a patient has the opportunity to refer them in. We do partner with our health department and utilize their care coordinators and their educators. So the care coordinators actually follow them with blood pressure checks routinely, many times a month. We also have education that's centered around physical activity, stress management, diet, and nutrition, things like that that historically a physician or a primary care provider don't really have the time to really go over. And one of our key components to this, I feel, is that we enlist the support of community pharmacists to sit down and go over and conduct medication really reconciliation or assessments, and also medication adherence. And you know, Gus talked about that. One of the things that always that struck me, one of the first things that struck me when I joined Blue Cross was A, how interested they are in paying for medications that are written, and B, the number of people that don't fill the medications that their doctor gives them. You know, I knew when I practiced, if I wrote that down, because I had the greatest practice in the world, I give somebody a script, it was filled, they took it every day, and holy smokes. I mean, those of us that have an opportunity to look, we see that it's really abysmal. And then we followed NQF 18 guidelines, and we would graduate people once they met their NQF and maintained it. We have 5 counties in really south central Oklahoma. They're rural counties. This was very interesting to me because of some of the work I'd done with Blue Cross of Illinois on the Advocate ACO. Many of y'all have heard of that. It's the largest ACO in the United States. And as we try to roll these programs out to some of the smaller states and rural areas, we found that you know, it's like asking everybody to put their foot in a size 8 shoe. What fits for one won't fit for others. And so you have to really design these programs so that they work best. As I said, we've got 5 contiguous counties in the southeast part of the state. So we've seen some really good results from the Million Hearts, similar to what Gus has talked about, and Paul knows this, we report on it. But really I want to talk to you about why we're a participant, why it's important for us to do it. You know, I said I practiced for quite a while. I was very blessed, and I had a very unique perspective. So when I decided to retire, and I found out my wife's idea of retirement was different than mine, coincidentally, I obtained an offer to come to Blue Cross. And I was struck by many things that good-natured people don't think of, that many of us that deal with patients every day consider second nature. And, you know, we don't want to discriminate anybody based on sex, race, the card that they got in their pocket, for God's sakes. You know, we want to treat everybody the same. And payers were wondering why in the heck some of these, and I'll call them, because that's what we call them in our state, value-based care models, anything from pay to performance to full global risk, why they didn't work so well. And they don't work so well because we as payers go out and say, we want you to treat our members this way, but we're not going to help you with anybody else. And that just really stuck in my throat. The other thing that our state health department does not run our Medicaid. We have the Oklahoma Healthcare Authority that's responsible for Medicaid. And so some of the things that I thought we could bring to the table, besides, you know, the fact that we do have some funds and we can incent behavior, is the fact that we do have strong relationships with our providers pretty much all across the state. And we wanted to leverage those relationships. And we were excited about leveraging them in rural communities because we'd been doing some stuff in more metropolitan areas and big health systems. But again, back to that size 8 shoe, we wanted to figure out, because we're a rural state in Oklahoma, and if you look outside of Chicago and outside of Dallas, Houston, San Antonio, all our markets are mostly rural, and we needed a solution for a lot of our members. So we really wanted to leverage that relationship that we had, and we took it upon ourselves to try to incent people and providers, both, to participate. I said there were some things that kind of took me by surprise when I joined the payer world. And one of the things that probably surprised me the most was the fact that they really thought they were paying for health. And I think many people up here talked about that, but really, and we just always say they're paying for units of care, you know, or ill care. So my challenge was to figure out, how do you pay for health? How do you define it first? And then how do you measure it? And then the paying for it's pretty easy once everybody agrees on the same page. So that was really what we wanted to, again, work with our providers to do. Next was the data. You know, we have access to large amounts of data. We're part of the Blue Cross Association, so it's one of the largest medical databases there is, but it's all claims data. And, you know, I kind of shocked the people when I said, when you're trying to predict the future with claims data, it's like spray painting your windshield black, using your rear view mirror and trying to get to Vegas. You know, it's tough to tell what's coming based on what you encountered. And so it became clear to me, because I came from the clinical world, that, you know, we had a piece, but like I said, I didn't know what the payers paid for, what was filled. I knew what I wrote. They didn't know what I wrote, but they knew, or what I discontinued, they just knew when they got a claim for that. And so I was very interested in marrying our data with clinical data. And really, clinical data is not just a practice data or a hospital system data. We took it upon ourselves to say anybody that touches a patient has valid data, and we want to see it. Because if they're affecting the care of the patient, they need the global picture of everybody else that's taking care of the patient. And so that was huge. And I'll talk a little bit about the HIE that we have that is one of the most remarkable things in the state of Oklahoma. Lastly, public and private collaboration. You know, it's part of that having a responsibility to your community. And so it was important to us to be the leaders of every community in our state and in all of our states. So we wanted to develop that relationship. But I had to figure out how I'm going to sell that to the folks that are not necessarily clinical or as focused on patients. And I like to call them patients. We're members. I always say I'm a member when I don't need health care, and I'm a patient the minute I do. And so I try to make that distinction. Also, as I looked into the Affordable Care Act, and We're on the exchange in all 5 states. We feel that's a commitment that we should make. As I look at that, and you really get down, you see that the lines are now being blurred between who had insurance and who didn't, or who had a public coverage with Medicaid and who next month switches over to the exchange, who was on a group and then moves to individual. And so it became clear to me that we needed to work together with everybody that's paying for care, even people that are competitors that, you know, historically payers didn't like. But you needed to work with everybody that's paying for care so you can align programs. And in doing so, you know, you really strengthen relationships and develop trust. And that's what we use as we try to move forward. And with that development of common programs by collaborating with all payers, and we do it in the primary care initiative. We're one of the 7 regions. We're also a SIM plan grant recipient. So we are trying to walk the walk, if you will. And it's something that it takes up a lot of effort sometimes. So lastly, I just want to talk a little bit about our opportunities. You know, I said that I played a part of some of the work with the large ACO in Illinois, and then I played some in some smaller ACOs in Texas and some that we have in Oklahoma and medical homes. But the rural piece was what really interested me because, you know, we need to get to where the lion's share of our members lie, and that's in rural communities. So we wanted to use this as a laboratory, just like we're using the comprehensive primary care as a laboratory, to try to develop, you know, programs that fit the community and fit the physicians and fit the people that are taking care of the patients. Because I will tell you that I can't roll out an ACO in rural Oklahoma. It just doesn't work, as you all know. Next, I wanted to do what I could to try to expand the scope of value-based care. And value-based care, as I said, is anything from a pay-for-performance, bridges to excellence, medical home, intensive outpatient care model, ACO, global payments, bundled payments, episodes of care, and full at risk. And so we need to figure out how we can develop models. You know, it's like Nike's building a bunch of different shoes in a bunch of different sizes, and we need to do the same darn thing. And so that's really one of the other things that I felt like was important to us. And lastly, you know, I said we have an unbelievable health information exchange in the state of Oklahoma. It's called My Health Access Network. We don't own it. We don't own any shares of it. It's like a rural electric cooperative. Any of y'all familiar with those, you understand it's really owned by your members. It kind of appeals to me because that's the way the Blue Cross plans that I'm associated with are. It's owned by the members, it's controlled and governed by the members, and it's not a payer or a provider group that's trying to control this data. And so, quite honestly, this was a big hurdle. You know, I said we're the largest non-investor-owned payer. We're the 4th largest. This is the only HIE that we've ever shared our data with, is the one sitting in Oklahoma, because it's really designed the way it should be. It aggregates all of these data sets with anybody that's touching a patient, and it's created actionable data at the point where the care is being delivered. And, you know, to me, as someone that knows, studies have shown, it depends on your population, but in the adult population, the average adult that's in the healthcare system, because if you know, those of you that are in my world, look at how many people that you are paying for insurance that don't even access health care. And we think, some of us think that's wrong because there's always preventative services to be delivered. But of the adults that do, you know, they average near 7 different doctors within a 12-month span. And so how do we get physicians to think outside of what they see in their practice and expand that world? It's sharing the data that a patient got when they saw you, so that when I'm seeing it, I understand that you did that CT scan, or you were in the ER and you saw that patient and the CT was done this weekend. Now they're in my office, so that I don't have to. And if you don't think it's done, I was probably the worst because I had a big practice. Somebody come see me Monday or Tuesday, it was in the ER. If it was going to take somebody in my office 2 hours to get that results, I repeated them, because that's the way it's done, and you have to be expeditious. But if you can prevent those things, you will ultimately give a better picture of that patient to whomever is treating that patient at the time they're being seen. And it'll also do things like make it more accurate when the diagnosis is made. It will, if you're decreasing redundancies, you're going to save costs. And lastly, if you're not driving the patient all over creation, repeating stuff and sticking them again, they're going to be happier, because I guarantee the outcomes are better and the satisfaction goes up. So that's why we participate in Blue Cross, and I'll just leave it at that. Thank you.